Thank you very much, John, and thank you to Mairead for the invite, and really looking forward to the next 2 days. I think we're going to have a really good discussion and also some agreements in relation to how we move forward. I really like the first talk in terms of take the lead, because that's what we need to do. We need to be leaders, not laggers. You're probably looking at me and saying, why is he putting the Wall Street Journal up as his first slide? Surprisingly, for a scientist, I do actually read the Wall Street Journal occasionally. I was really struck by this article in 2011. The new Einsteins will be the scientists who share. And that was really important to what I'm going to talk about over the next 25 minutes, because it really influenced the way we thought about how we would actually drive cancer research and its implementation across Europe, and actually even wider than that. At the time, about maybe 10, 11 years ago, we decided to come up with a big data for better health strategy. And this became in 3 parts. And the first part was breaking down the silos. Unfortunately, at the time, and some of this still prevails, academic researchers, clinicians, industry all kept the data like this, as if it was their own data. It's not their own data, it's the patient's data. But there was really no sharing of data, and people were trying to maximize what they could do with their own little piece of data rather than actually looking at how could we do things differently. We sought to change that. A group of us came together under something called the Global Alliance for Genomics and Health, and really looked to ways in which we could get academic researchers, clinicians, industry, and patients to really just collaborate, to share data, to share code, to look at developing solutions to problems that we could actually do together. And some of these were big problems. The second thing was learning from that data, and also recognizing that there are very many different data types. So whereas we think in terms of genomic data, clinical data, things like environmental data, socioeconomic data are also really important. So it's having that much more wider viewpoint in relation to what data actually means. And the third was looking at ways in which we could actually use that intelligence to improve the health and well-being of the citizen, but also to contribute to economic and societal benefit, and also to contribute as an evidence base for influencing policy. I will give you some examples of that. Probably our philosophy was reflected in this paper that we published in the New England Journal in 2017, where we looked at this idea of a cancer data knowledge network. So moving from that closed, selfish silo approach to a much more open and open source federated culture. The second thing, and those of you who would have been in this field for a while, you may remember the Cambridge Analytica scandal in relation to collecting data without patients' or individuals' approval or even their knowledge. And so one of the things we did as well was brought together a cohort of the willing, or a collaboration of the willing, to really say that we need to both maintain, but also in some situations restore trust of the public in the use of data. If we look in terms of what we did then in the United Kingdom, we decided to bring all this together in relation to looking at ways in which we can look at clinical data, radiological data, genomic data, pathology data, etc., under something that we call DataCan, the UK's Health Data Research Hub for Cancer. And there's 4 principles really that underpin DataCan. The first is improve access to data, enhance the quality of that data, collect it and use it under fair principles. But I'm actually going to look at the 4th one and highlight that this is really important. Ensure fair value. And that means that in order for this to work, is you really have to have a situation where everybody gets fair value. First of all, the patient. Secondly, the health service. Thirdly, the academic researcher. And fourthly, industry. If there's an imbalance in relation to that relationship, that we don't get fair value, then it won't work. And there are many myriad examples of situations where that hasn't worked properly. One of the things that we did was place patients at the heart of what we do. And this is not a tick boxing exercise. When we wrote the grant that led to the development of DataCan, which I'm privileged to be the scientific director of, we had patients involved in that writing of the grant. They're at all levels of decision making, so they sit on our strategic management board, they sit on our steering committee, they sit on individual project boards as well. So that enables us to really have genuine co-creation of research, because it's simply embedded in the fabric of DataCan. We involve patients in discussions with all our research partners, academic, but also commercial partners. The patients are the key gatekeepers of the data projects that we agreed to do, and they have the power of veto. They haven't actually exercised that power of veto. They've exercised the power of saying, well, actually, if you did it this way, or if you collected this data, or if additionally you collected patient-reported outcomes, it would make it a much better study. And both academic partners and commercial partners have come back to us and said, this really works, because you're actually proving a better project than when we started off trying to develop this project together. So it's a real co-creation, patient involvement, and patients are the ones who make the final decisions. The other thing that's been really important is looking at ways in which we have underserved and minority communities involved, so that the voices are not just one voice of one particular community, but are multiple voices. Jackie Gath is a breast cancer survivor who I work very closely with, and I just love this phrase. I quote it quite a lot. Patients want their data to be used to improve care and to enhance research. In fact, they're often surprised that it's not used already. And that's our common experience in relation to data studies that we perform, both with academia and with industry. We set up DataCan, and then we had to essentially pivot. And for me, COVID-19 was very personal. My uncle died of a COVID-related illness in the first months of the pandemic. And one of my colleagues over on the left-hand side there, Edward Vidoliak, who's an oncologist in Croatia, while he was reaching out to me to sympathize with me on my loss, he said the following thing that really scared me. He said, people in Croatia are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. And with my good friend and colleague, Richard Sullivan, we sort of thought about that and said, are we seeing that in the UK? We're maybe hearing some anecdotal stories, but there's really no data to tell us whether what Edward was saying was true or not. So we decided with Harry Hemingway and Alina Lai to do a collaboration to access data from hospitals in near real time right across the UK, including all the hospital trusts in Northern Ireland, and to look at see what was the impact. The best experiment is the simple experiment. Don't look at 50,000 variables when you can look at just 2 and get the answer. So we decided to keep this very straightforward. As I said, data in near real time from hospital trusts around the UK on a weekly basis. And what we found was that during that pandemic, that initial phase of the pandemic, 7 out of 10 people with suspicion of cancer were either not going to their GP or not getting referred on for specialist cancer services that would diagnose whether it is a cancer or not. And 4 out of 10 cancer patients were not getting access to their chemotherapy at the appropriate time. That was really scary data. Straight away, we sent a letter to each of the 4 chief medical officers before we published it or anything to really get that message across. This was the first evidence of the impact of COVID on health systems and cancer patients in the United Kingdom. We then presented this data to WHO Europe and also to the European Cancer Organization. European Cancer Organization saw the seriousness of what we were presenting and immediately set up a special network on the impact of COVID on cancer, which I'm privileged to co-chair with Miriam Krul, who's a pharmacist in the Netherlands who is leading the vaccination effort there. We performed another pan-European study this time, and the data was even more dramatic. That's not a misprint. 100 million cancer screening tests not performed, 1 million cancer patients perhaps undiagnosed, significant impact particularly on surgery and chemotherapy in terms of treatment, slightly less so for radiotherapy, and I can explain why that is. And also citizens and patients less likely to attend either screening appointments if they're citizens, or go to hospital for their cancer treatment if they're patients. And finally there, and this is specific to cancer healthcare workers, but probably the data is similar for other disciplines as well, 4 out of 10 feeling burnout, 3 out of 10 showing signs of clinical depression. And unfortunately, all this data that I'm presenting to you is still being felt by the cancer community throughout Europe. What did we do? We decided we needed a campaign. We needed to get this knowledge out there, first of all, but also we needed something to be done about it. So we presented our data to the European Beating Cancer Committee, and then we set up a Time to Act campaign to ensure that cancer was at the very top of the European health agenda. We brought together different countries from throughout Europe, and we got them all to sign a petition in relation to the Time to Act campaign, and you can even see there in Irish down in the bottom corner. I didn't translate that, okay? So did it work? Did our data-informed campaign have any impact? I guess when the President of the European Commission, Ursula von der Leyen, is quoting your data, and Stella Kyriakides, who at the time was the Health and Food Safety Commissioner, again referred both to the Time to Act campaign and again quoted our data, that we must have been getting something right. The recommendations that we put forward were incorporated into the EU COVID report. We won a number of awards as well for the work. And it's very simple to use. You can still go onto the site and look at it in terms of comparing countries, comparing regions, etc. But it has been very impactful. Now going to move from Europe to Northern Ireland and just talk about something that I think is very relevant to the island of Ireland. And it's looking at how do we drive a digital health agenda. We decided a number of years ago that we would develop a digital transformation of our health system. The project was called Encompass, to have a digital health and social care record for every citizen in Northern Ireland, and also to have a My Care app so that you could actually, either on a website or on your phone, get that data. It's a journey that we're still on, but it's been a journey that's been really interesting in relation to looking at ways in which we can work together. Essentially, we now have implemented Encompass through an EPIC system in four of our six hospital trusts. And so we started off in the Southern Trust, we then went to the Belfast Trust, and then we've been going. So the idea is that everybody in Northern Ireland, so 1.9 million population, will have a digital record. Every time I come back to the Republic of Ireland, as you can tell, I'm not from Northern Ireland, I say one thing. Why do you not have a digital health record, and why do you not have a unique patient number? Thankfully, it looks with the legislation that's going to be brought in that that will finally happen, but you really need to catch up, I'm sorry. So Michael Quinn and Francis Burns have been leading this effort to really look at a digital vision, because this is going to transform the way we deliver health, and in our situation, the way we deliver cancer. But right from prevention to treatment to identifying patients for clinical trials, it's really important. Again, I'm happy for these slides to be shared with everybody, so I'm not going to go into incredible detail in relation to this. We've set up a data institute with Health and Social Care Northern Ireland, really looking at transformation as to how we share data, how we access data, how we look at not only secondary data but also primary data through the GPIP system. We're still on that journey, so I'm not saying we've solved all the problems, but it is really important. And one of the things we have is the Northern Ireland Trusted Research Environment that Francis is leading, so that we can have a safe use of health and social care data with evidenced, clear patient benefit. Looking at ways in which we can drive innovation. There's a lot of innovation we can do in this sector, and also how we collaborate and partner going forward. One of the things we did was we signed a time-limited MOU between Queen's University Belfast and Health and Social Care Northern Ireland. We deliberately made it time-limited because what we wanted to do was do a number of projects that ended up being 7 projects, mini projects that were both proof of principle but also proof that we can actually work together between the university and the health system. What we will do then is, we've called them proof of value concepts. We have a number of cancer ones, but also ones in other areas, for example, a renal project as well. And the idea is that this shows us that we can do it, and then we will scale, and then we will look at answering the big challenges that we're facing, the number one of which is waiting times in hospital. And the second thing that was really important, and Francis has very much taken the lead on this, is having that conversation with the public. And this is through a first public panel that's been created for data use in Northern Ireland. They had their first meeting back there in October. And again, I think this is a conversation that we could have on an all-island basis, and certainly would be very interested in sharing some of our experience. And it's not that we haven't done things on an all-island basis already in cancer, we have. And through the auspices of the Good Friday Agreement, a memorandum of understanding was signed in 1999 between Ireland, Northern Ireland, and the US National Cancer Institute, facilitated a lot by the Health Research Board, and particularly Ruth Barrington, who was CEO at the time, looking at enhancing cancer research, cancer control, and it's had a significant input or impact in relation to cancer care improvement and cancer research on the island of Ireland. We published this paper back in 2020, just showing some of the impact that we've seen. And that led to us going to the National Cancer Institute, meeting with our senior leadership and saying, can we continue to do this program? Because the program had been very successful in the first 10 years, have probably drifted a bit in the next 3 or 4. We, as I said, presented this data to them to show this really has made a lot of impact, a lot of difference. They agreed with us. Bill DeHoot, who was clinical director of the NCI at the time, said that Ireland and Northern Ireland are now firmly embedded on the global cancer research map. And that support and that senior leadership from the NCI led to the re-signing of the agreement on the 16th of March 2021. You can see the 2 ministers at the time, Robin Swan and Stephen Donnelly, and the director of the NCI at the time. So again, a historic day for the island of Ireland, where we actually came together again to look and see how can we work together. And what had we achieved? You can see, if we look at this study that we did, and Norm Sharpless and myself presented it in a special session with The Economist, looking at we doing more together in terms of joint publications, but what was particularly important is we were doing it better together. So we developed a quality index to show that we're actually doing things much better as well as much more. 40,000 patients now have been enrolled in cancer clinical trials in the island of Ireland, again, mainly driven by the Health Research Board setting up the centres throughout the country. And there's been a 10 to 15% improvement in survival. So this does work. The other thing it's allowed us to do is actually do a very significant training program with the NCI, initially through Queen's University, Belfast, where students go to the NCI and they're supervised by mentors in Queen's and in the National Cancer Institute. We've 7 students, 5 of them have now been vivaed, will graduate at the next graduation. And when we were over there in 2023 celebrating this collaboration and this partnership, and you can see Mairead there, the comment to me that really stuck with me, these students are fantastic, where can we get more of them? And thankfully, through funding that's come through, mostly the Health Research Board and some funding from the equivalent R&D research organisation in the north, we will now have a all-island doctoral training programme. This legacy of the Good Friday Agreement we presented around the world, and we've been very fortunate to be able to present it at the Science Summit of the United Nations General Assembly in 2023 in New York. And it's now recognised as a health legacy of the Good Friday Agreement, and it's recognised internationally in relation to that. I think we all know that cancer is time sensitive. And again, in terms of using data and working together, one of the things that we've done is brought together a partnership through the HEA funds, through the Shared Island Fund, an eHealth hub for cancer led by Aideen Culhane in the University of Limerick and myself in Queen's. And that's allowed us to really look at ways in which we can work together on the island of Ireland. And I think this is really important. Yes, we might say we've different health systems, but health systems shouldn't know a border. Cancer certainly knows no borders. And so ways in which we can work together, we're really looking at, and looking at creating an all-island federated data network where the data will still stay within the institution, but allow us to actually look at ways in which we can work together. And we're very excited about some of the developments. Again, we're still at an early stage, but it really is something that we feel is going to be important. The other thing is we need to have some type of report that tells us what is the pathway, what is the blueprint. So we had our special forum, first cancer forum, a lot of cancer data forum there in January in the University of Limerick. And one of the things we've done is actually reached out to the community, looked at ways in which we can capture what are the practices that are being done in the community, and to really issue a call for action, which we hope to do in the next couple of months, to harness the potential of data to transform cancer research, cancer policy and care, but most importantly, cancer outcomes. Just going to give you a couple of examples of how we've used data and how it's been really effective, particularly in the policy front. Those of you who treat bowel cancer or colorectal cancer will know for advanced colorectal cancer, cetuximab is the treatment of choice. Interestingly, in England, if you are on cetuximab therapy and your doctor, your oncologist says you should take a treatment break because of complications, etc., you cannot do that in England. If you do that, you go off the study and you won't get funded. You'll have to pay out of your own pocket if you want to actually get the treatment continued, which obviously is an unacceptable inequality. So no deviation from the protocol. So we partnered with Bowel Cancer UK. We are the biggest bowel cancer charity in the United Kingdom, and collected patient testimonies, looked at the clinical evidence in terms of was there any difference, but also performed very comprehensive health economic both modeling and analysis. And what we found was that this treatment break approach, as we call it, would not have any negative impact on survival, might have some positive impact in relation to quality of life, but could save the health service $1.2 billion every year. I'd like to say that the evidence that convinced the NHS to change their mind was the patient testimonies or the clinical evidence, but it wasn't. It was the health economic data. So it led the NHS England to end their ban on treatment breaks, and this turning data into evidence is a really good example, I think, of how we can use data to directly help our patients. A second example relates to what was said earlier in relation to the cancer workforce and in terms of the whole medical workforce. So this is not a cancer-specific example, but just to show you some of the cancer data that we produced and some of the UK version of that. You can see there, workload seems endless. Half of UK cancer physicians, administrative rules, work exhaustions, high levels of burnout. I'm guessing, but you can confirm with me, that these numbers and what they're saying is probably not that different in Ireland. So what we did was we looked at essentially a project, a really interesting project, and I'd encourage you, if you're interested, I can organise for you to see the project in action. Luke Redman has set up this project in London. It's called One London. Essentially, it's taking a population of approximately 9 to 10 million in London and looking to see how can you create a digital London. It involves 5 integrated care systems, 40 NHS trusts, 1,400 general practices, and 33 local authorities. And essentially, what they've done is they've set up a London care record. It's used during 2023 when it was set up 17.7 million times, 100,000 staff, viewed about 2 million times. Luke asked us, would we do an evaluation of this after 18 months of its going through. We showed that it saved approximately 2 million per month, and it saved the equivalent of 44.4 million, but also it's saved significant time of staff. And it's also saved time of staff who actually shouldn't be doing the administrative work, but should be doing the front line, but are spending time inputting things and essentially reading things, photocopying things, PDFing things. Why should they be doing that? That is not their talent. Their talent is looking at patients. And so we can see there it's had significant benefits. It's improved staff and systems efficiency. It's reduced costs, and we also feel it's probably enhanced patient safety. We're about to undertake a follow-up of that study because we're now nearly 2.5 years in to actually see the benefit. So the future is definitely digital. I'm privileged to be chair of the International Cancer Benchmarking Partnership, which is a global collaboration where we look at differences in cancer survival and how we might mitigate that, how we might learn from each other. Ireland and Northern Ireland are part of this, as are the 4 nations of the United Kingdom. And you can see there Australia, Scandinavia, Canada, etc. This is just one example, looking at consistency of cancer policy. And what we did was we developed a study where we looked at consistency of cancer policy in all of the jurisdictions that we looked at, so about 22 jurisdictions. And out of that, we developed a policy scorecard. Unfortunately, and I've had to do this in many different fora, I have to stand up and say that Northern Ireland does worse. Why does it do worse? Because its cancer strategy, rather than being activated, was sitting on the shelf. Ireland is probably about mid-table in relation to that. But if you look at Denmark, Denmark is now at the top of that table. And that's particularly interesting because if you look at Denmark back in around 2000, it had the worst cancer outcomes and mortality in Europe. But then they decided to do something about it. They said, first of all, cancer is the top priority in health. Why did they do that? They actually did that because they were embarrassed. The second thing they did was they invested in radiotherapy, centralized surgery, screening. You can see there the different things. Again, I'm not going to go through them in detail. They're still on a journey. But if you look at it here, and this is just comparison within Scandinavia, you can see the improvement has been significant. And I could show you similar looking at the 22 jurisdictions. So yes, they still have a way to go because they were very far down. In 2000, they were even below the UK in relation to cancer outcomes and mortality. So what about the UK? One of the things I say is our policies must match our opinion. And how do you not do it? So in 2022, Sajid Javid, who was the Secretary of State for Health at the time, announced with much fanfare and some bullishness a war on cancer, echoing what Richard Nixon said in 1971. Less than a year later, they'd subsumed that cancer plan into a major conditions strategy based mostly on opinion. I think opinion is the lowest form of evidence. We presented our data in the House of Commons to the Health and Social Care Select Committee on the future of cancer. And you can see me there with Julie Graylow, who's the Chief Medical Officer of the American Society of Clinical Oncology, because we wanted to say, you know, what you're doing in the UK is wrong. It doesn't reflect best international practice. Our key recommendation was restoration of a national cancer plan as a matter of urgency. So let's be leaders, not laggers. And this is the problem. This is the unavoidable truth. And this is why it's really important to have data and to use it to influence how we make decisions. 28 out of 33 in OECD countries for 5-year lung and stomach cancer. The 62-day target that we set from referral to first treatment hasn't been achieved since 2015. 40%, you can see there the data, 92% of cancer centres delays in patients starting chemotherapy. It's just not on. And part of the reason is because we haven't taken cancer seriously in the UK in the last 5 to 10 years. And if you look at it, if we actually invested and improved the level of care, even to the mean level of other similar high-income countries, look at the amount of lives we could save and look at the amount of return on investment that we could get. Because obviously if we're curing patients, if we're detecting them earlier, we're actually saving money for the health system as well as saving cancer patients. So after 14 years of gross mismanagement, if you see here, Wes Streeting, who's the Secretary of State for Health, in September said he was thinking about it, based mostly on our data. Stephen Kinnock, who's Neil Kinnock's son, came out and said, we are going to do it. And then just before Christmas, on the 20th of December, Wes Streeting said, we are going to create a national cancer strategy. But there's talk that that may take a year. So what do? You go to Westminster. And you go to Westminster with a van, with a screen on the side of it. And it might help a little bit if you have Brian Robson, Captain Marvel, Captain of England and Man United legend with you. Because that's allowed us to really drive the agenda. In the House of Commons, we had hired a room, quite a small room. We had 106 MPs who came mostly, not to talk to me, but to get their picture taken with Brian Robson. But when he's there, and when they're there, you make sure to have 5 seconds, 20 seconds, a minute, or whatever, talking with them. We then brought our petition to Downing Street. I've been a Manchester United supporter since 1969. Most of you probably weren't born in 1969. So it was a special privilege for me to meet with Brian, who unfortunately is a cancer survivor. Not unfortunately, he's obviously fortunate that he is a cancer survivor from throat cancer. And he's been a great advocate. And one of the things we realized was that cancer won't wait, patients can't wait. And so we've really pushed the agenda to say, yes, Wells Streeting, you've agreed, you're going to produce a cancer strategy, let's get it now. We've given enough evidence. The evidence is there. We can provide more evidence, but it's going to say exactly the same thing. Give us our cancer strategy. Thank you very much.